Pampanga. Pampanga. Okay, you may now teka muna. Oh, Antipolo. Dami-dami Antipolo. QC. QC 44. Baba na po kamay. Valenzuela. Ay, 100. Baba na po kamay. Baba na po kamay. Charissa, Alexis, Alisa Marie, Joyce, pakibaba na po kamay. Kibero. Gibero and Charissa, pakibaba na po kamay. Ulitin ko po, Kabanatuan, 5, 6, 7. Okay, pakibaba na po. Konti pa lang Kabanatuan. Ulitin po natin, Pampanga. 23. Pakibaba na po kamay. Hello, Doc.
Yes, sir. Yes, sir.
Okay na po. Pwede na po mag-start.
Okay. Thank you,
Thank you.
sir.
Record ko
Thank you,
po,
sir.
Doc, ha?
Thank you po.
Okay.
Sir, ikaw na magre-record? Someone else? Kasi ako pwede.
Ako na po, Doc. Ako na po.
Namamatay kasi ako. Nawawala ako sa Zoom.
Opo, ako na po. Thank
Okay.
you.
Okay, sir. Alright, good afternoon,
Recording in
everyone.
progress.
Magandang hapon, Fatimanians. Rise to the top. Handa ka na ba? Preparing you all for the board exam. Rise to the top. My name is Dr. Areglo from Fatima QC. Hello, everyone. Magandang hapon. Okay?
Good afternoon.
Na-miss ko rin kayo. Good afternoon. Magandang hapon.
Magandang
Fatima
hapon po.
All
Good afternoon po,
Magandang
Doc.
hapon, San Fernando, Cabanatuan.
Good afternoon po.
Good afternoon, QC, Valenzuela. Ano, may nakalimutan pa ba ako? Ano pa bang meron? Okay, so MS na. Eto na, this is it. O, di ba, kayang-kaya niyo to. Di ba, magaling tayo sa MS, di ba? Okay, so, class, I prepared muna. Huwag kayo matakot, ha? Nag-prepare muna ako ng parang diagnostic test. Hindi naman to re-record, okay? At saka naka-PowerPoint tayo. Okay, so nag-prepare ako ng PowerPoint. Okay, digestive system muna tayo ngayon, ha? Para makita muna natin yung ano, oh, please ma'am, we have a foreigner in our midst. Wow. Sir, ha? Hindi mo in-inform. Oh my God. Inglesan ito. Okay, so my dear foreign students, please chat with me. Okay, chat with me if you don't understand. So I have to repeat it. Sometimes, you know, for us lecturers, sometimes we're already at the peak of our lecture. Sometimes we use Filipino or Tagalog to convey easier para we can understand it better. But if you don't understand, please tell me so. Okay? Ayan, kaya hindi niya naman ako in-inform, foreigner. Naghirap naman mag-English. Okay, anyway, as I was saying, I prepared, very short 30-item pre-tests. Okay, this is about digestive system. We will do the test first before we start our lecture. So after the exam, we will do our rationalization, and then after which we're going to proceed to our lecture. Okay, is that okay? And please use the chat box for interaction. You may not unmute yourself, that's okay, okay? But please do interaction through chat. Sanay ako dyan, so I'm used to it. So I'll be using the chat box for our interaction. So my dear foreign students, if you don't understand, please chat with me. I am more than willing to repeat the discussion for you if you don't understand or if I am saying it all in Filipino. Okay? Okay, ready na tayo? Game na ba? Yes? Game na po? Okay. Game na. So we will do it like this, okay? So you have to answer all the questions first. You have to be honest in answering them, okay? O na, pang board exam na ito, we are already preparing you for the board exam, for the international exam. So please, okay, answer honestly, okay? You may write all your answers first before you send it to me, direct message, okay? So wag one by one. You have to complete the numbering first before you submit all, okay? So you will be given 50 seconds to answer each question. Okay, if you did not finish it before the end of time, it's okay. We will just be going back to it. Okay? Ready na tayo? Game na? Okay, so we will start off with number 12. Number 12 talaga ang start, mga anak. Number 12 talaga. Are you seeing my screen now? Are you seeing my screen? You are seeing my screen? Yes.
Yes, ma'am.
Okay, very good. All right, so you may start answering now. You start with number 12. Start with number 12. Start with number 12. You may start it right now. May timer sa ilalim. Do not give me your answer yet. Do not give me your answer yet. Ipunin niyo yung answer niyo. Lagyan niyo ng number 12, ganon. Tapos direct message, anak, not to everyone. Okay? Ipunin muna. Compile your answer first. Okay? Everything first. And then chat it with me by direct message. Alright? Okay. So number 12, your answer. Number 13, your answer, etc. Alright? I said
Oh.
compile your answers first. Okay. So you have to answer first from 12 to 31 before you submit it through direct message. Okay. Do not answer one by one. All right. Okay. Anak, until 31. Until 31. From 12 to 31. For a while ha, nawala kasi yung timer for a while. Mga anak, for a while again, how for a while po. Sa papel niyo po isulat yung mga sagot ninyo. Huwag po diretso sa gadget, sa papel. Sa papel. So you write your answers on your papers. Okay? Papers. Write the answer in a sheet of paper. You will not pass it to me. Okay? And then you have to tell me your answer later when we do our discussion. Okay? Do not answer in your gadget. Write them in your paper. Okay? Okay. Maganda. Okay. All right. Okay, so that was it. So I think the total was 20 items from number 12 to number 21, right? Okay, so I hope you have your answers with you. So we will do a rationalization. You can send your individual answers during the rationalization. So I told you to write your answers on a piece of paper so you can actually send your answers to me during our rationalization. Okay? Okay, so let's start. Excited for rationalization. That's good. Pati man yan sa rise to the top, ha? Rise to the top. Okay, so let's start off. So I would like you to now give me your answers before I do rationalization, okay? All right, and then we will have our discussion. So for number 12, you have your answers with you. Which of the following instruction is appropriate for a nurse to give to a patient who has GERD? Okay, keyword appropriate. Appropriate. So what are we looking for? Right or wrong statement? What are we looking for? Right or wrong? Come on, answer me. Right or wrong? We
Right.
are looking for the right statement. Very good, because it's appropriate. Okay. So the patient has GERD, right? So GERD. What is the major manifestation of GERD? Heartburn or pyrosis. So the goal in the management of GERD is to prevent reflux, to prevent pyrosis. Okay. Which of the following now is an appropriate nursing action or instruction? Letter A, take prescribed antacid before meals. How do we administer antacids? Antacids are given after meals, usually 30 minutes to 1 hour after meals. We will wait until all the acids are released before we can neutralize it. So A is wrong. We are looking for the right statement, right? Letter B, place blocks under the legs of the head of the bed. So if you want to understand it very well, okay, so for example, this is the bed. Okay, let us make it block. So for example, this is your bed. Okay, yan. This is the head of the bed. All right, this is the foot of the bed. If you're going to place block here on the feet of the bed or on the head, legs of the head of the bed, okay, so what will happen? So the bed will be positioned like this. Okay, so the person now will be positioning with upper portion of the body elevated. Are we preventing reflux? Yes or no? Are we preventing reflux? Yes or no? Yes.
Yes,
Is that the correct statement? Yes, very good. Eating high fat and low protein diet. Okay. High fat. Is this appropriate for GERD? No. Okay. Low protein diet? Okay, no. Lie down 1 hour after eating. You cannot lie down 1 hour after eating, because if you can lie down, then you promote reflex. For number 12, the goal in the management is to prevent reflux. So the best answer would be place blocks under the legs of the head of the bed. So when you sleep at night, the upper portion of the body is elevated. That is your answer. Number 12 is letter B. 1 point. Very good. Rise to the top. Those who made mistakes, it's okay. It's okay to make mistakes. Okay? The most important thing here is we learn. This is not a recorded quiz. Okay? We are learning. Yes. Okay. Number 13. This is how we rationalize, okay? A nurse would assess a patient who has undergone total gastrectomy for early symptoms of dumping syndrome. Okay, gastrectomy. This is removal of the stomach. So when you remove the stomach already, there is no more storage of food, right? Yes. So there is a rapid emptying of food now into the small intestine. and that will predispose the patient to a condition called dumping syndrome. Okay? Now, the key word here now is you are already fourth year. I'm sure you understand what dumping syndrome, but I will explain it later. Okay, the key word here is early. The early symptoms of dumping. Okay, so what is happening to a patient with dumping syndrome? Because of rapid gastric emptying. Okay, so suppose this is the stomach. Okay, suppose this is the stomach. Okay, then we remove the stomach. We remove the stomach so that the stump of the stomach now is connected to the small intestine. So there is no more storage of food. So there is rapid gastric emptying here. Now, rapid gastric emptying, which contains high concentration of carbohydrates or sugar, okay, this sugar will attract water from the blood vessels, okay? So if this is the blood vessel of the intestine, the carbohydrate will attract water into the intestine. So what will happen? So what will happen? There will be abdominal cramping, there will be diarrhea, correct? Yes, okay, the patient will have diarrhea, the patient will have abdominal pain. Will the patient have decreasing blood volume? Yes, decreasing blood volume will decrease the blood pressure. And the earliest manifestation is early. Okay, diarrhea is correct, but abdominal distension is not. There is no abdominal distension in dumping syndrome. There is cramping, yes, but there is no abdominal distension. Diarrhea is okay, but there is no abdominal distension, so this is wrong. Okay? So what is the best answer? There is no facial flushing in dumping syndrome. So the best answer is letter A. Diaphoresis, the best answer is letter A. Diaphoresis, okay, that is sweating, and lightheadedness. Why? Because the body is compensating because of decreasing blood volume. Okay, so the key word there is early. Diarrhea is early, but there is no abdominal distension. There is more of cramping. I got you there. So the answer for number 13 is letter A. 2 points. Don't worry, we'll be discussing this again. Okay? Hindi naman masakit pag mali. Oh, of course, hindi naman masakit pag mali kasi wala naman tayong score. Wala pa daw siyang tama. It's okay. Okay, number 14. My dear foreign students, can you follow? Do you understand?
Yes, ma'am.
Thank you. All right. Which of the following statement, if made by the patient who has diverticulosis, would indicate to a nurse that the patient is following a diet plan correctly? Again, keyword, correctly. Right or wrong statement? Right or wrong statement? Right statement. Very good. Okay. And you have to know what diverticulosis is, correct? What is diverticulosis? Diverticulosis is a condition characterized by formation of diverticulum in the colon. Okay, let us talk about diverticulosis first. This is an outpouching. Suppose this is the colon. Okay, this is the colon. Okay, and this is your diverticulum. Okay, this is an outpouching. All right. What is the cause of this? We do not know the exact cause of this. But one most important risk factor is one, aging. Because as we grow older, the muscles here in the colon will already decrease, and the elderly will have less intake of water, so the patient is prone to constipation. So if the patient is constipated, you increase the pressure inside the colon, and that pressure will actually push the formation of a diverticulum. So if it's only one, you call it diverticulum. If you have several of this, you call it diverticula. And the condition characterized by the formation of several diverticula is called diverticulosis. And patients will have no clinical manifestation unless there will be inflammation. And if there is inflammation, the condition is called diverticulitis. Okay. To prevent that, we need to prevent one important risk factor, which is constipation. So what is the correct diet plan? Okay, very good. So the answer is letter D. Hooray! Did you get it right? Rise to the top. Very good. Tumama din daw. Okay, that's number 14. Don't worry, we'll be discussing them later. Okay. Okay, number 15. Are we learning? You know, I can just discuss the lecture with you, but I would like to see first, no? How do you attack questions in the examination? So I hope if we can finish the digestive today, tomorrow we'll have another one like this, right? Okay, number 15. The nurse should expect a Sengstaken Blakemore tube to be ordered for a patient who has bleeding esophageal varices in order to, what is the purpose of Sengstaken Blakemore tube? This is being done to patients with liver cirrhosis, okay, especially those with esophageal varices. This is a triple lumen tube that is inserted into the esophagus to compress the blood vessel and to prevent bleeding. What is your most important, what is the answer? To be ordered for a patient who has bleeding. So in order to, so what is the possible reason for that? The possible reason is, anak, you are putting Sengstaken Blakemore tube. You have to ensure airway patency. That is very correct. But it is not the purpose of it. Because the question is, in order to. So what is the purpose of putting the Sengstaken Blakemore tube? The Sengstaken will not ensure airway patency. But it will apply direct pressure to the area. So you are compressing it to prevent rupture of the blood vessel. So number 15 is letter D. Yes, very good. Did you get it right? Yo! Ayan, rise to the top. Oh yeah, rise to the top tayo. Okay. Number 16. Which of the following factors, if noted in patient's history, would indicate a predisposition for developing cholecystitis? Okay. Class cholecystitis is inflammation of the gallbladder, right? This is inflammation of the gallbladder. And the risk factors for, the most important risk factor for cholecystitis ay gallstones, correct? Yes, okay, gallstones. And what are the most important risk factor for gallstone production? Correct. That's your 4 F's. This is common among female, fat, 40 years old and above, and fertile. So among all the choices, obesity will go for the fat as one of the risk factor. Very good. Number 16 is letter A. Yay! Marami nang correct. Marami nang correct. Very good. Okay. Next, number 17. A client with cirrhosis may have alteration in which of the following lab values? Which of the following lab values? Okay, very good. Liver cirrhosis. Okay. Carbon dioxide level may be altered if there is a lung problem. Correct. The ALT, diba? This is the one, we call it liver enzyme. Okay. If there is injury to the liver, then these enzymes will be elevated. Okay. Erythropoietin is produced by the kidneys. Okay. And the pH naman can be regulated by the kidneys, the lungs, and the blood. So the answer here is letter B. Check. Very good. Yan, alam na alam mo yan. Okay, alanine transaminoglycinase. Very good. Number 18. A client with acute pancreatitis asks the nurse when he will be able to eat again, or what is your most appropriate response? Now we have different answers, huh? Okay. So acute pancreatitis is diagnosed by increasing pancreatic enzyme level, right? So what are the enzymes that are elevated here? The lipases and the amylases. And the most destructive enzymes are the lipases. So when do you know that the patient is getting better? The patient is getting better when the pancreatic enzymes in the blood are already going down. Okay? So the patient now may start eating when the blood test for enzyme improve. Very good. So number 18 is letter C. Very good. Letter C tayo. Number 18 is letter C. Yes, very good. So, pasado tayo ha. Number 19. The nurse would expect which of these assessment finding in a client with duodenal ulcer. Oh, duodenal ulcer. So how are you going to differentiate gastric ulcer from duodenal ulcer? Do they have differences? Of course. Okay. So assessment finding for duodenal ulcer. Now, one test-taking strategy class is actually to remove obvious wrong. What is an obvious wrong? There is no positive fluid wave. This is seen in patients with ascites. So this is not correct. So you have to remove it. So if you remove the obvious wrong, you lessen your choices. When you lessen your choices, you increase the chance of getting the correct answer, right? Okay. Distended abdomen is not a sign of ulcer unless there are complications. That is not for ulcer. So you only have two. Epigastric pain occurring at night or epigastric pain relieved by vomiting. What is your answer? The best answer is letter A. Very good. Duodenal ulcer pain occurring at night. Why? Because there is continuous gastric emptying when we sleep. Okay. So if you eat at around 7 p.m., okay, then gastric emptying happens 2 to 4 hours after eating. So by 8, 9, so that's the start of your gastric emptying, 10, 11. By 11 at night, the gastric contents has already gone through the duodenum and it will irritate the duodenal ulcer. So there is more pain at night. So the patient will be awakened by pain. And what will the patient do? The patient will eat because eating will close the pyloric sphincter and that will relieve the pain of the patient. Okay? So epigastric pain relieved by vomiting is characteristic of not duodenal ulcer but gastric ulcer. Not duodenal ulcer but gastric ulcer. For number 19, the answer is letter C. Okay, we will be discussing that. Don't worry. Okay. For number 20, yes. The client had a total gastrectomy. So you remove the entire stomach. The nurse should teach the client about long-term treatment for which of this condition. The stomach produces intrinsic factor, very good, that is needed for vitamin B12 absorption. So the problem here is vitamin B12 deficiency. What type of anemia will develop in your patient? What type of anemia will develop? Pernicious anemia. Class for a while lang po, 1 minute. All right, so number 20 is letter C. Okay, next, number 21. I think you are getting good scores. So yeah, very good. Okay, 21. In caring for a client with hiatal hernia, which of the following should be included in a teaching plan regarding the cause? Now, hiatal hernia happens when there is too much pressure in the abdominal area. So that pressure in the abdomen will actually push the stomach upward, which results to gastroesophageal reflux. Okay, so included in a teaching plan regarding the cause. Okay, everybody is correct. So the answer is letter A, avoid heavy lifting, because heavy lifting will increase intra-abdominal pressure that will promote um, herniation of the stomach. Okay, so 21 is A. Yes, okay, 22. The most fatal complication of choledocholithiasis is ascending cholangitis. What is choledocholithiasis? Okay, which may complicate to the development of what type of shock? Okay, well, you know already that cholangitis is inflammation of the common bile duct. Okay, if there is inflammation, most likely the patient will be dying of or complicate to the development of septic shock. Okay, how does this develop? Okay, let me discuss. Okay, let me discuss. Choledocholithiasis is this is stone in the common bile duct. So a stone in the common bile duct. So suppose this is the, so for example, this is the liver. This is the liver. Example, this is the liver. Okay, and then this is your gallbladder. This is the hepatic duct, and this is the gallbladder. For example, the cystic duct and the common bile duct. For example, this is the common bile duct. Then this is the small intestine, right? Okay, and there is a stone in the common bile duct. Okay, it's stone. So this is called choledocholithiasis. Therefore, the bile cannot actually pass through here because there is an obstruction. Will there be backflowing of bile? Yes. Okay. Will the patient become jaundiced? Definitely. If there is a stone blocking the common bile duct, one clinical manifestation of this patient is jaundice. Okay, and of course, the patient will have right upper quadrant pain. Okay, and the danger of this is this thing. Since there is no more bile here, so the bile will only be here, and then this part of the common bile duct becomes empty, right? So what will happen? The bacteria in the small intestine, we have normal bacteria in the GI tract, will actually go up in the common bile duct. That is why it is called an ascending cholangitis. Will it cause inflammation of the common bile duct? Yes. So aside from jaundice, right upper quadrant pain, the patient now will manifest fever. Okay, these three class is what we refer to as the Charcot's triad. The Charcot's triad of ascending cholangitis. So if the patient is having jaundice, the patient is having right upper quadrant pain and fever, this is the Charcot's triad for ascending cholangitis. Will the patient be susceptible to shock? Yes. What type of shock? Septic shock. And how do you know if the patient is already having shock? The patient is already having shock. Okay, that is septic shock. If, number one, the patient has jaundice. Number two, the patient has right upper quadrant pain. Number three, the patient has fever. Number four, the patient has hypotension. And number five, the patient has confusion or altered level of consciousness. Okay, jaundice, right upper quadrant pain, fever, hypotension, and confusion. This is now what we call the Raynaud's pentad. The Raynaud's pentad. The 5 signs or clinical manifestation that the patient is already having septic shock. Secondary to what? Secondary to ascending cholangitis. That's pentad, anak, kasi we have 5 already. 1, 2, 3, 4, 5. So that's Raynaud's pentad. And this 1, 2, 3 is the Charcot's triad. Are we learning? Rise to the top. Yes. We need another top notcher from your batch, huh? Yes. Okay, very good. Shall I erase now? Can I erase now? Top 1. Yeah, very top 1. Yes, okay. Number 23. Yeah, rise to the top. Okay. A client with liver cirrhosis has severe ascites and experienced difficulty of breathing. Which of the following is your priority intervention? What is the cause of difficulty of breathing in a patient with ascites? The cause of difficulty of breathing in a patient with ascites is actually compression of the diaphragm. Let us draw a stickman. I cannot draw a very good drawing. I will just draw a stick person. Okay, this is a stickman. Okay, a stickman. Okay, then this is your ascites. Okay, so there is fluid in the peritoneal cavity. So the increased fluid in the peritoneal cavity is actually compressing the diaphragm. Okay, so this is the reason why the patient will have difficulty of breathing. So what is your nursing diagnosis? Ineffective breathing pattern. Okay, so how do we manage that? How do we manage? We want to prevent compression of the diaphragm. So what do? You do paracentesis at once. Okay, we need to put the patient on a reverse Trendelenburg. Very good. This is your answer. When you say reverse Trendelenburg, how do you position the patient? This is your head of the patient. Okay, then this is the body of the patient. So this is the reverse Trendelenburg. So when the reverse Trendelenburg, fluid gravitates here, correct? Yes, okay. So the diaphragm will not be compressed because the fluid is gravitating downward. So this is called reverse Trendelenburg. So the initial action of the nurse is position the patient. What position? Reverse Trendelenburg. So 23 is letter C. Rise to the top. Doc, question, useless po ba ang nagpaparacentesis yung patient with liver cirrhosis? Of course not. Paracentesis is really a management for ascites. But class, the patient is already having difficulty of breathing. So we have to prioritize that. And to be able to lessen that difficulty of breathing, you have to place the patient first on a reverse Trendelenburg. That is our priority. Remember, airway, breathing, they are always our priority. Now, after you position the patient, maybe you prepare for paracentesis as the doctor will order for it. Okay? So the best answer is letter C. Rise to the top. Okay, number 24. Yeah. After pyloroplasty, which of the following intervention prevent rapid gastric emptying? What is pyloroplasty? Pyloroplasty is actually a repair of the pylorus. Okay, it's actually widening of the pyloric sphincter. Suppose this is the esophagus. Okay, wait, let us put it here. This is the esophagus, for example. Okay, I'm sorry, I cannot draw very well. This is the stomach. Okay, this is the pyloric sphincter. Okay. Now, as the food passes through the stomach, diba, the pyloric sphincter will close. It will close. Okay. The lower esophageal sphincter will close also under normal circumstances to give time for the food to be digested in the stomach. Now, in patients with gastric ulcer, okay, we do not want the food to remain in the stomach to lessen the irritation of the ulcer. So what we do is to repair the pylorus. When you repair the pylorus, you open up, you widen it. So the food will not stay in the stomach anymore. It will go rapidly down the small intestine. Okay, which of the following intervention will prevent rapid gastric emptying? Okay, letter A, simple sugar in the diet. Letter B, low protein intake. Okay, letter C, liquid must be taken in between meals. Okay, or all of the above. Okay, let us try to eliminate first obvious wrong. Okay, what is the obvious wrong? In patients with rapid gastric emptying, dumping syndrome may happen. Okay, and dumping syndrome is stimulated by food high in carbohydrates, especially simple sugar. So giving simple sugar will not actually prevent rapid gastric emptying. It will even promote your dumping syndrome. So this is an obvious wrong answer. So if A is wrong, then letter D is wrong also. Correct? So you only have two choices. Low protein or liquid must be taken in between meals. Okay. In patients, no? Okay. Dumping syndrome happens due to one, rapid gastric emptying, and number two, intake of simple sugar or carbohydrates. So to prevent dumping syndrome, we need to prevent rapid gastric emptying and prevent administration of simple sugar or carbohydrates. Okay. So to prevent that dumping syndrome, what should be the food of the patient? Okay. The diet of the patient should be low carbohydrate, no simple sugar. No, low carbohydrate, no simple sugar.
Aguli, nasa klase kasi ako eh.
Okay. Okay. Then should be high protein. Why high protein? The high protein will prevent fluid shifting. Okay. This will also prevent diarrhea. Okay. And moderate fats. Moderate fats. Because moderate fat will slow gastric emptying. So the protein should not be low. It should be high. So this is not the answer. So there is one thing that is left. Liquid must be taken in between meals. Because if you take the liquid during mealtime, the water will actually push the fluid and it will promote more gastric emptying. So the answer is letter C. Maghula. Huwag namang maghula. Dapat alam natin. Okay? Don't worry, we will be discussing them. Okay? So, next. We are learning, I hope. Okay? Instinct daw yan, hindi hula. Okay. Di po kasi naintindihan. Oh, you have to understand the question very well before answering. That's the most important thing in testing style. Okay. Then attack the question as is. Question. Answer the question. If you question the question, you're over-analyzing already. And if you over-analyze, you will get it wrong. Like this one. A client with possible appendicitis is being assessed. Which of the following is not contraindicated? It's not contraindicated. So meaning, it is allowed. Negative, not contraindicated. So positive. Negative, negative, positive. Right? It's not contraindicated. Okay? Okay, what is the answer? Cleansing enema is contraindicated. Why? Because this will promote rupture. Warm compress will also promote rupture. Yes, laxatives, which is not in the question, will also promote rupture of the appendix. We do not want that to happen. Is digital rectal exam contraindicated? Yes or no? What is digital rectal exam? You can put your fingers on the rectum and examine the rectum. Is that contraindicated? Yes or no? Yes or no? Yes or no? Is digital rectal exam contraindicated? Yes or no? No, it is not contraindicated. The finger will not reach the appendix. Correct? It will just be the assessment of the rectum. So digital rectal exam is not contraindicated. Diba? You cannot do this. You cannot do this. You can do it. You can do this. Because it is okay. But we can do digital rectal exam. Correct? Yes. So number 25 is letter B. You will tell me your score, huh? In all honesty, direct message to me, give me your scores because I will see if there will be improvement later on. Okay? Okay. Fourth year na kayo. You should be very honest with your test taking, ha? Okay. I in IBS means, what is your answer? Bawal po ba mag-coffee pag appendicitis? If we are actually thinking about appendicitis, the patient should not be taking anything by mouth anymore because there is no cure to appendicitis but surgery. 100% A, sabi niya. Incredible daw. So the answer is irritable. Okay, irritable bowel syndrome. Okay, inflammatory is an inflammatory bowel disease. So that's different. So IBS is not the same as IBD. So if it is IBS, then you say it's irritable bowel syndrome. Okay. Okay, next, number 27. A clinic nurse is providing health teaching for a patient newly diagnosed with GERD. Which of the following needs further teaching? Further teaching. Are we looking for a right or a wrong statement? Again, right or wrong statement? Right or wrong? Wrong statement. Very good. Okay. So the wrong statement, sabi na ulit 100%. Ako dyan. Okay. The wrong statement is letter A, change of dietary pattern to small frequent feeding. This is correct. However, bedtime snack is not correct. Bedtime snack is wrong because after eating, you may lie down and that may cause further GERD, right? So the answer for 27 is letter A. Yes. Okay. Then we have 29. 28. Sorry. Post-operatively, the patient develops dumping syndrome, which of us that further dietary teaching is necessary. Right or wrong? Right or wrong? Right or wrong? Wrong. Again, further dietary teaching is necessary. So what is wrong here? What is wrong? 28. What is wrong? Dumping syndrome is stimulated by rapid gastric emptying and high carbohydrate diet. O, anong wrong siya? Okay. Letter A. Bread is carbohydrate. You should not be taking a lot of it. Letter C is correct because to prevent dumping, you should lie down after meal to slow down the gastric emptying. Okay. Yung iba nalilito na. Okay. In GERD, we don't lie down after meals. GERD, do not lie down after meals. But to prevent dumping, you should lie down after meals. Okay? So you have to see what is the problem. Ulit, in GERD, do not lie down after meal. But in patient, to prevent dumping, you should lie down. Oh, magkaiba nga pala. So the answer here is letter A. Okay. Nagutom ka na. We will eat first, ha? Number 29. A client with peptic ulcer in the duodenum would probably describe the associated pain as, again, the difference between duodenal and gastric ulcer. So, letter A, an ache radiating to the left side. No, duodenal ulcer, even gastric ulcer is epigastric. So you remove letter A already. Right? Letter B, intermittent colicky flank. No, it's not in the flank. Flank is on the sides, diba? It should be on the epigastric. So B is letter B is wrong. Knowing sensation relieved by food. Relieved by food. Yes, that's duodenal, diba? Okay. Sabi po kanina, need kumain para mawala ulit. That's correct. Relieved by food. That's correct. Okay, a generalized abdominal pain intensified by moving, that is wrong. So the best answer here is letter C. You have to eat. Because when you eat, the pyloric sphincter will close, so there is no further irritation to the duodenal ulcer. So the answer is letter C. Okay, number 30. The nurse is providing instructions. Okay. Sige anak, wait lang na, tapusin natin ito. Then I will go back to where you want me to go back. A nurse is providing instruction to a client about measures to minimize the risk of dumping syndrome. The nurse tells the client to do which of the following? Again, minimize the risk. So you have to think of it. Prevent gastric emptying, rapid gastric emptying, and prevent carbohydrate intake. Okay? So, what do you do to minimize the risk? Letter A, increase fluid intake, particularly at mealtime. You cannot do that because the water will actually push the food. So that will increase your gastric emptying. A is wrong. Maintain high carbohydrate. That is also wrong. Maintain low Fowler's position. That's recumbent. That's a supine, diba? You're lying down, correct? That is to prevent your gastric emptying. Ambulate, no, you cannot ambulate, but because that will promote more gastric emptying, correct? Okay, so the answer here is letter C. Okay, we are learning here, class, learning time. Yes, okay. Okay, then we have number 31. A client being treated for esophageal varices has since taken Blakemore tube inserted to control the bleeding. The most important as ito, you are being asked about assessment. Earlier, you are being asked about the purpose of the since taken Blakemore tube. Now, you are being asked on what do you assess. Siyempre, priority is your respiratory status, airway, because the esophagus is right beside the trachea. The trachea is anteriorly located and the esophagus is posteriorly located. If you put taken Blakemore tube and inflate the balloon, it may cause compression of the airway. Airway is priority. Sabi nga nung aking kasama sa center, airway ka ba? Bakit? Kasi priority kita. Oh, diba? Okay, so what is your score? Did you pass? Tapos na to, diba? 31 only. Uh, did you get 60% of, what is 60% of 20? 60% of 20. What is 60%? 12? Okay, so very good. So if you learned, if you got a lot of mistakes, that's okay. And then we are learning from our mistakes. Opposite ng 31, 30. Anak, hindi to 31 items. 20 items lang to. Tama ba? 20 items lang to. So 6 times 12. Tama? 12 is that. They failed. It's okay. So we should be learning more. Pasado. That's correct. Okay. So 12 is the passing mark. Okay. Let us now have our lecture. Lecture muna. Okay. So we'll talk about the digestive system. Oh, question in the last board exam. Let's pray for our kuyas and ates who took the board last week. The results will be out before the end of this month. So we hope and pray that they will pass. Most of their questions is digestive system and endocrine. Okay. So I hope we remember here. So digestive system, I just want to give you a small anatomy and physiology. It's actually made up of two parts. We have the gastrointestinal tract. Okay, dun siya sa taas. We have the gastrointestinal tract. This is a very long tube. Okay, and this is also called alimentary tract or alimentary canal. Actually, this was a past board exam question, alimentary tract. Okay, and then we have the accessory organs of digestion. Accessory organs of digestion. The accessory organs of digestion, they are not really part of the alimentary tract, but their secretion will help in the digestion of foods. So these include your liver, of course, the largest internal organ of the body. This is the largest internal organ, but the largest organ of the body, of course, is the skin. Okay, the liver is the largest internal organ, but the largest organ is the skin. Okay, we have the liver, we have the gallbladder, we have the salivary glands, correct? And of course, we have the pancreas, salivary glands and pancreas. Now, for the GI tract, we have the upper GI tract and the lower GI tract. And their division is really very important. Plus, tell me, the upper GI tract will start from the mouth, okay, down to the, from the mouth to the, nagkagulo na sila. From the mouth down to the small intestine. Okay, and the lower GI tract is from the large intestine down to the anus. And this is a very important clinically. Okay, very important clinically. Why? Because you remember this, complete digestion takes place in the upper GI tract. Complete digestion takes place in the upper GI tract. In the lower GI tract, there is no more digestion. No more digestion in the lower GI tract, such that if there is bleeding in the upper GI tract, the blood will be digested together with food. So you are seeing digested blood in the stool. So you don't see them fresh. You see them digested already. So in the upper GI bleeding, what you see is melena. So the blood becomes black, or the stool becomes black and tarry. Okay. Now, if there is bleeding in the lower GI tract, there is no more digestion. So the blood will pass out fresh in the stool. The condition is called hematochezia. So if there is active bleeding, okay, active bleeding, fresh bleeding in the stool, then there is a problem in the lower GI tract, because in the lower GI tract, there is no more digestion. What is happening in the lower GI tract then, especially in the large intestine, if there is no more digestion? What is happening? This is very important. Number one, there is reabsorption of water. Now, this is the reason why, if you have colostomy in the ascending colon, you have liquid stool coming out from your colostomy, correct? Because of the reabsorption of water, this fluid fecal material, as it passes the transverse colon, they become semi-solid. So if you have colostomy attached to the transverse colon, the fecal material become mushy, they said, or semi-solid. Now, because of the reabsorption of water, as it passes down the descending colon, the stool becomes solid already. That's why if you have colostomy attached to that, you see the fecal material solid already. Are you following? Yes. Okay. Number two. Another function of the lower GI tract is that this is responsible for synthesis of vitamin K. The E. coli in our colon synthesize vitamin K for us. Yes. 50% of our vitamin K, we get it from the E. coli, produced by the E. coli, and 50% from the food that we eat. And what do we need vitamin K for? Vitamin K is needed for production of clotting factors 10, 9, 7, and 2. Without vitamin K, we cannot produce these clotting factors. So these clotting factors, we call them vitamin K dependent clotting factors. So you tell me, why do you inject Vita K to newborn babies? To prevent bleeding. How? We give Vita K to newborn babies because there is no production of vitamin K from the colon yet. They do not have E. coli yet, and they don't have food intake yet. And we want to help the liver to produce clotting factors. That is the reason that you will not cause bleeding to happen, because the clotting factors are complete. Correct? Yes. So vitamin K is given because they need it. They don't have E. coli yet. They don't have food intake yet. But their liver needs this vitamin K to produce your clotting factor. Isa po yan sa question sa exam. Question sa exam? CA1? Are you sure? CA1. Meron na ba to sa CA1? Hindi ba wala pang MS sa CA1? Peri o MCN? Pedia. Yan, newborn. Correct. Oo nga pala. Pedia. Ala ko MS eh. Very good. Okay. So another function of your of large intestine. There is no more digestion. Okay. So another function is putrefaction. Putrefaction. What is putrefaction? This is the process, okay, by which the E. coli act on fecal material. The E. coli will act on fecal material, yeah. And what is their product? Their product are gases. Gases coming out of our anus as our flatus. What type of gases? All types of gases. Carbon dioxide. Even carbon monoxide. Really? Yes. Methane. Ammonia. You know, I believe in one of the advertisement that death starts from the colon. All of these gases are deadly. And this is because of putrefaction. Okay, so these are all the gases produced by the large intestine. All right, learning ba tayo? Yes. Okay. Very good. Okay, now let's go to the disorders. Okay. Okay. To simplify the discussion of digestive disorders, I divided them into two groups. Okay, I divided them into two groups. Okay, we have the inflammatory disorders, and non-inflammatory disorders. Non-inflammatory disorders. Okay, so when you say inflammatory disorder, this is easy. It's very easy to do the pathophysiology of an inflammatory condition because you have the same signs and symptoms. Everything that ends in itis can be inflammatory, right? So we have gastritis. Peptic ulcer disease is a form of an inflammation. You call it erosive inflammation. Peptic ulcer disease is inflammation. Then we have IBD. The I here is inflammatory bowel disease, okay, which is actually your Crohn's disease. Oh, you remember this now, Crohn's disease and very good. No? Yung mga estudyante ko dyan sa MS to, sa may mga notebook nyo. Balik po sa last slide. Ay, oo nga pala, in the number 27, I'm sorry. Naka-open na po. No? Okay. Okay ka na. Sorry. Okay. So, the regional enteritis, okay, this is your, I'm sorry, Crohn's disease is also called regional enteritis. Okay, and then the other one is ulcerative colitis. Okay. O, balik muna daw. This is the last slide. Anak, yung number 27, okay ka na? Sure na ha? Sorry, nakalimutan ko. Oh, this is the last slide. Okay na po? Okay na. Okay. Alright. Ayan. Another inflammatory disease. Okay. We have appendicitis, tsaka diverticulitis. Then, we have cholecystitis and pancreatitis. I don't discuss hepatitis in MS, obviously, because that must be tackled in what subject? Hepatitis daw. Anong subject? Hepatitis. CDN, correct. Much of the questions in the board exam also last time was CDN. You have to understand CDN. Bakit? Pandemic time, infectious, very important for all of us. Right? Okay. So, for non-inflammatory condition, okay, so we have IBS. What is IBS? This is irritable bowel syndrome. Then we have hiatal hernia. Okay, my students are answering. Congratulations. Thank you for your notebook. And liver cirrhosis. Very good. Okay. I don't discuss gastric cancer. I don't discuss pancreatic cancer. I don't discuss liver cancer because obviously that should be discussed in oncology. Right. My discussion with my MS1 kanina was oncology. Okay. So these are all the inflammatory diseases and the non-inflammatory. Okay. With inflammatory conditions, I said, if you have inflammation, all processes, all signs and symptoms are the same. Because those are signs and symptoms of inflammation, correct? Okay, so what are the signs and symptoms? So, number one manifestation of inflammation is definitely pain. Okay. The most common complaint of patient is pain. How do we assess the abdomen of the patient. Board exam question. In the assessment of the abdomen, when the patient complains of abdominal pain, we follow the AYA-PEPA. AYA-PEPA. Very good. I for inspection first, then auscultation, then very good, percussion, okay, then palpation. Why? Why do we have to start off with auscultation? Because percussion and palpation will actually may affect our auscultation. To prevent rupture po pag pinapalpate, pag possible appendicitis. Okay. Anak, we are just on the assessment. We are not discussing appendicitis. Okay. Okay. Palpation and percussion should be after the auscultation because they may affect bowel sounds. They may affect bowel sounds. Okay. That's why AYA-PEPA. And you have to remember that the abdomen is actually divided into either 4 quadrants, the right and left, upper and lower, with the umbilicus there, tama? Or we can actually divide it into 9 quadrants, okay? So we have the 9 quadrants here. Ayan. And then we have the umbilicus here, okay? So this is your right and left upper quadrant, right and left lower quadrant. This is epigastric, umbilical, hypogastric, right and left hypochondriac, right and left lumbar, right and left iliac. Okay, so when the patient complains of pain, what do you do first? Assess. Assess, assess, assess. Okay, the nurse will do assessment first. Remember that, okay? You assess. And when you assess, you inspect first. Okay, then you auscultate. Okay, and then you percuss and palpate. And ask the patient, where is the pain? Where is the pain? Okay, I will tell you where the pain is. Okay, for gastritis and peptic ulcer disease, the pain is in the epigastric area. Okay, for Crohn's disease, okay, the pain is located in the right lower quadrant. For ulcerative colitis, the pain is in the left lower quadrant. For appendicitis, the pain is on the right lower quadrant. For diverticulitis, the pain is on the left lower quadrant. Okay. For cholecystitis, the pain is on the right upper quadrant. And for pancreatitis, the pain is on the left upper quadrant, radiating to the back. Okay. So these are the different locations of pain. All of them will have pain. So if you have the same signs and symptoms, you have the same nursing diagnosis. What is your nursing diagnosis? Acute pain or chronic pain. Okay. Another clinical manifestation of an inflammatory disorder is nausea and vomiting. Why? Why? So vomiting happens when we stimulate the vomiting center. The vomiting center is called chemoreceptor trigger zone. This is our vomiting center. It is located in the brain. This is the CTZ. Okay. And anything that will stimulate the CTC will cause us to vomit. Anything that stimulates the CTC will cause vomiting. Okay, anything that stimulates the CTC will cause vomiting. So what will stimulate them? This will be stimulated by, number 1, any inflammation in the abdominal region will cause vomiting. So all of them will cause vomiting, right? inflammation. Letter B, any obstruction in the abdominal region will cause nausea and vomiting. Stone in the gallbladder, stone in the common bile duct, stone in the ureter. Okay, it is stimulated by that. What else? Letter C, increase intracranial pressure. That will stimulate. Letter D, vertigo or dizziness. All patients manifesting vertigo will have vomiting as well, right? Okay. Oh, what else? What else? Okay. Very good. Anti-cancer drugs. Anti-cancer drugs can cause vomiting. They can stimulate the CTC. Okay. Or anything that may, that may provoke your imagination. Okay. Something that you see, something that you hear. Diba? It may cause stimulation. Foul smell, correct. Okay. Gross, anything that is gross, you do not like that. So that may stimulate the CTC. So all inflammatory conditions will have one, pain. What is your nursing diagnosis? Acute pain. All inflammatory conditions will have nausea. What is your nursing diagnosis? Nausea. Nausea is a non-accepted nursing diagnosis. Vomiting. Nursing diagnosis, risk for fluid volume deficit. Risk for metabolic alkalosis. Diba? Okay, what else? Okay. Patients with inflammatory disorders of the GI tract, let us highlight the signs and symptoms. We have pain for inflammatory disease. We have nausea and vomiting. Okay, for inflammatory condition, the patient may also have indigestion. Indigestion is also called dyspepsia. And luckily, indigestion is already an accepted non-diagnosis. So for all these inflammatory conditions, we have the same signs and symptoms. If you have the same signs and symptoms, then you'll have the same nursing diagnosis. Okay. All right. Risk for complications. Correct. Okay. So how about non-inflammatory disorders? Actually, I would like to start off with the non-inflammatory disorders before we discuss all of this. By the way, do you still want me to discuss all these inflammatory disorders, or we can just make exams and rationalizations, or you want me to discuss again? Discuss. Discuss and exam. Wow. Demanding to mga to. Upon auscultation, ano pong maririnig pag may indigestion? Okay. When you auscultate the vowel sound, you tell me what is the normal vowel sound? The normal vowel sound is about 5 to 35 per minute. 5 to 35. So you have to listen in all quadrants and listen for 1 full minute. In patients with indigestion, it does not necessarily mean there is problem with vowel sounds. Okay, vowel sounds may be hypoactive or hyperactive in conditions such as abdominal cramping, if the patient is having diarrhea, or if the patient is having partial obstruction. In complete obstruction, then the patient may not have any vowel sounds anymore. But in indigestion, so it will be depending on what is the cause of indigestion to be able to correlate it with your vowel sounds. Okay. Okay. All right. O, sige. I don't have any prepared questions. I thought I will be discussing. So, siguro let us discuss a little then, and then tomorrow I will be preparing for the exam. Okay, diba? Kasi 20 exams ang questions lang ang wow. So, maybe I will be discussing non-inflammatory conditions. Okay, and for inflammatory disorders, I will be making questions. Okay, and then we'll do rationalization. Is that okay? Okay, I am hungry. Can we take dinner first? Break time. Yes. Okay. So let's have a break first before we continue. I will be discussing irritable bowel syndrome, hiatal hernia. I don't know if I can still discuss liver cirrhosis, but if I don't, then tomorrow we will have exam and ratio for all of these conditions. Okay? And then we'll discuss endocrine. All right? Are we learning? Oh, Fatimanians. Ang sagot, rise to the top. Ganyan ha. Ulit. Fatimanians. Ayan. Rise to the top. Yan. Very good. Sige, let's eat first. Okay, I'll see you later after 20 minutes. Is that okay? 20 minutes? Okay, all right. Hello? Narinig ka. Okay, we're back. Balik na tayo. Game na ulit. Discussion na ha. Discussion. So that tomorrow na ako mag-exam ulit. Okay? Tomorrow na discussion muna para meron tayong lecture. Okay? Yan. Okay. So open ako ng chat box. Yan. Okay. So I said we will be discussing the non-inflammatory conditions of the digestive system. So let's start off with IBS, irritable bowel syndrome. Irritable bowel syndrome is a functional disorder. We do not know the cause. Okay? Functional disorder. What is the etiology? The etiology, idiopathic. We do not know the cause. So why do you call it a functional disorder? It is a functional disorder kasi wala ka namang nakikitang structural defect. Walang inflammation, walang erosion, walang mass, walang tumor, nothing. So it's just a functional disorder. The patient may have signs and symptoms pero wala kang structural defect. I'm sorry, there are foreign students around. I'm sorry. Again. Again, irritable bowel syndrome is a functional disorder because there is no structural or anatomical defect. We do not know the cause of irritable bowel syndrome, okay? But they say that most likely this is secondary to a neural defect, okay, in the control of the digestive system or the gastrointestinal tract, or most likely this is a cause of hormonal defects, okay, so it can be either neural defect or hormonal defect, okay, so these possible problems may affect the GI function. But if you're going to see the anatomy and physiology of the digestive system, the anatomy of the digestive system, nothing is wrong with it. There is no ulceration, there is no inflammation, but you see signs and symptoms. We do not know the exact etiology, of course. There are certain risk factors. Yes, correct. Stress can be a risk factor. A family history is a risk factor. But we do not know the cause. Now, what are the signs and symptoms? No? IBS can be categorized as IBS-D. IBS-D means the major manifestation of this condition is diarrhea. Or it can be IBS-C, as the main clinical manifestation is constipation. Or it can be IBS-A. So when you say IBS-A, there is alternating diarrhea and constipation. Alternating diarrhea and constipation. So you have IBS-D, IBS-C, and IBS-A. Okay? So how do we know if the patient is suffering from IBS? Is there any diagnostic test? There is no diagnostic test. However, diagnostic tests are done to rule out other conditions. Now, for example, you have to do colonoscopy. Colonoscopy must be done not to diagnose IBS, but to rule out possibility of colon cancer, because one early manifestation of colon cancer is alternating diarrhea and constipation. Okay, we would like to check the CBC of the patient. We have to rule out possibility of an infectious process. You may see an elevated WBC. Okay, you would like to check the erythrocyte sedimentation rate. Erythrocyte sedimentation rate. Okay, if the erythrocyte sedimentation rate is elevated, then that will tell us that there is an inflammatory process. So we are actually doing all of this. You may want to do imaging tests like ultrasound of the whole abdomen. You want to check out if there is any problem there. If all of these are done, okay, and you don't see any problem, then that's the time we diagnose irritable bowel syndrome. So this is a functional disorder. So past board exam question include what is I in IBS? That's why I asked that in the examination earlier. And another question in the examination or passport examination is what is the characteristic diarrhea in patients with irritable bowel syndrome? So what is the characteristic diarrhea? Is it A, bloody, letter B, watery, or letter C, mucoid diarrhea? Okay, so the characteristic diarrhea is mucoid. That is correct. Okay. Is the patient also manifesting abdominal pain? Yes. Okay. The patient, aside from diarrhea or constipation or alternating diarrhea and constipation, may also have indigestion. Okay. The patient may also manifest indigestion. The patient may also manifest abdominal pain. Okay, so these are the clinical manifestations. So how do we manage? Okay, management of IBS is purely palliative, palliative only. When you say palliative, you relieve the signs and symptoms. Okay, palliative. So there is no cure, but you only have to relieve the signs and symptoms. So number one, what are the signs and symptoms? So number one is diarrhea. So if a patient is having diarrhea, so how do we manage them? Siyempre, we need to replace what is lost. So you have to give your fluid replacement. Oresol is really very important management for patients with diarrhea. What else? Diet. Okay. What is the diet of patients with diarrhea? Patients with diarrhea should be given high protein, that is to prevent the fluid shifting, and low residue diet. Low residue. Low residue is not low fiber. No, they are not the same. Low residue means you give food that will completely be absorbed and almost nothing is left for excretion. One best example of that low residue diet is rice. Yeah. So high protein and low residue. Okay. Then if the diarrhea becomes severe, then we may give anti-diarrheal drug. Okay, this is loperamide. Tama? Diatabs. Okay. Number two, we have constipation. So for constipation, again, we have to increase fluid intake. Okay, oral fluid intake. A lot of fluid. And the diet that is rich in fiber. Low fat, and high fiber. Okay, and in severe cases, then the patient might be given laxatives. Okay, so this is just palliative treatment. Now, if the patient is not manifesting anything, no, to control possibility of diarrhea and constipation, okay, control of symptoms, to control symptoms, okay, control symptoms, our diet should be low residue and high fiber. Again, if the patient has no other signs and symptoms and you want to control the symptoms of the patient, you do not want the symptoms to and high fiber. Am I loud and clear? My internet connection is unstable. Can you hear me? Loud and clear po?
Yes,
Yes, baka nagcha-choppy ha. Okay, all right. Okay, so this is your irritable bowel syndrome. No inflammation, no erosion, nothing. Okay, and one possible risk factor is stress and family history. IBS, remember that. Okay. Now, another non-inflammatory condition of the digestive system is your hiatal hernia. Okay, hiatal hernia. Okay, hiatal hernia. Okay, when you say hernia, we're actually referring to protrusion, a protrusion of an organ. Hiatal hernia is not the only hernia in the abdominal region. In Tagalog, yes, you call it luslos. Okay. But hiatal hernia is not the only hernia that we see in the abdominal region. We also have inguinal hernia, which is common among men due to the weakness of the abdominal muscle. So there is protrusion of the small intestine into the scrotum. And then for women, we have what we call femoral hernia. Femoral hernia is also due to the weakness of the abdominal muscle. So femoral hernia for women and inguinal hernia for men. So hiatal hernia is different. When you say hiatal hernia, there is protrusion of the stomach, protrusion of the stomach into the hiatus of the diaphragm. What is the hiatus of the diaphragm? Ayan. Tama ba spelling ko? Ayan. Okay, the hiatus of the diaphragm, no? Now, for example, this is the esophagus, and this is the esophagus. All right, and then this is the stomach. Okay. The stomach is in the abdominal cavity, and the esophagus is in the thoracic cavity. And these cavities are actually, these cavities are divided by a very, very big muscle called the diaphragm. This is the diaphragm. Okay. Now, this part of the diaphragm, the part of the diaphragm where esophagus enters the abdomen the part of the diaphragm where esophagus enters the stomach, this part of the diaphragm is called the hiatus of the diaphragm. Okay, so this is the hiatus of the diaphragm. Okay, this is the hiatus. Okay. Okay, the hiatus of the diaphragm. Pakibalik. Oh, here. Okay na? You tell me when you're done, anak. Okay. Here, I will repeat. Okay. So this is the esophagus, this is the stomach. And the esophagus is in the thoracic cavity, while the stomach is in the abdominal cavity. And these cavities are actually divided by a very big muscle called the diaphragm. Okay. So the area of the diaphragm where esophagus enters the stomach is called the hiatus of the diaphragm. This is the hiatus. The area of the diaphragm where esophagus will enter the stomach. That is the hiatus of the diaphragm. When this hiatus of the diaphragm becomes very weak, so there is a tendency for the esophagus to protrude upward into the esophagus. So this is your esophageal, this is your sliding hernia. So you call it hiatal hernia because there is a protrusion of the stomach into the hiatus of the diaphragm. Okay, what is the etiology? Okay, well, hiatal hernia can be congenital. Babies may be born with hiatal hernia already, but the hiatal hernia in the babies are different because severe hiatal hernia in children, when the baby is born, almost all of the abdominal contents are already in the chest. So an emergency surgery may be required for that. Okay. Our focus of discussion is hiatal hernia in adults. Okay. So this is actually the acquired type of hiatal hernia, and mostly because of an increase intra-abdominal pressure. So this is common among patients who are obese, who are pregnant, Ayan, because of increasing intra-abdominal pressure, right? Okay, so patients who do activities, no, activities like lifting heavy objects, okay, heavy objects, straining, yan, straining, okay. So anything that may cause straining or Valsalva's maneuver, IRE, okay. So anything that may increase the intra-abdominal pressure will actually push the stomach into the hiatus. Okay, so this is called hiatal hernia. There are actually types of hiatal hernia. This is the most common types of hiatal hernia. One is called the sliding hernia. This is a sliding hernia, okay, and the other one is called the rolling hernia. The rolling hernia is also called paraesophageal hernia. Okay, in paraesophageal hernia, the weak part of the hiatus is on the side. So you are seeing the protrusion of the stomach here in this area, here in this area. Okay, so this one is sliding, then this one is rolling. Okay, there is another type called the mixed type of hernia. So in the mixed type, you have both sliding and rolling. Okay, so this is the mixed type of hernia, both sliding and rolling. Yeah, that's the worst type, of course. So what is the danger of having this hiatal hernia? So that there is a tendency for the gastric juice to get up into the esophagus, okay? So what will be the most prominent clinical manifestation? The most prominent clinical manifestation is pyrosis or heartburn. So this hiatal hernia is one condition that actually causes GERD or gastroesophageal reflux disease. Okay, so this is one condition that may cause gastroesophageal reflux disease. Okay, so that's the most prominent clinical manifestation. What is your nursing diagnosis? Of course, acute pain. Okay, what is the danger of a reflux? What is the danger of the reflux? You know, the only acidic portion of the GI tract is the stomach. The acid in the stomach will protect the stomach against entry of a foreign body. Kasi diba, the stomach is filled with food. So it should be protected against entry of microorganism. Only one microorganism can live in an acidic environment that is causing peptic ulcer disease. We call them H. pylori. The H. pylori is secreting a substance that neutralizes the acidity. That's why they can live in an acidic environment. But other than H. pylori, many bacteria cannot live in an acidic environment. And besides, the acid of the stomach is needed for activation of protein enzymes. This is the reason why our stomach is acidic. Now, the esophagus is not acidic. No. So if there's going to be a reflux, then the esophagus will be exposed in the acids coming from the stomach. So there will be exposure of these to acid. Okay, and the acid exposure in the esophagus may cause irritation, injury, and inflammation. Irritation, injury, and inflammation. I will write that, okay? So the hydrochloric acid from the stomach may cause irritation and injury to the esophagus. Causing what? Causing esophagitis. So esophagitis can be a complication of GERD. Yes. Now, aside from pyrosis. If the patient develops esophagitis, then the patient will have difficulty of swallowing. You call it dysphagia or painful swallowing. Painful swallowing is called odynophagia. Okay, so esophagitis can be one complication of your GERD or hiatal hernia. Okay, and not only that, okay, if there is frequent exposure of the esophagus, frequent exposure of esophagus to the frequent exposure of the esophagus to the hydrochloric acid, so there will be changes in the cells of the esophagus. You know, the cells of the esophagus is actually lined by squamous cells. So this is the natural cells of the esophagus. And the stomach is actually lined by columnar cells. It is lined by columnar cells. Okay. Chronic exposure of the esophagus to the hydrochloric acid may cause changes in the esophageal cells. So from the squamous cells, it may change to become columnar as well. So chronic exposure to hydrochloric acid, irritation, injury, and inflammation may cause a change of the esophageal cells from squamous to becoming columnar. From squamous to becoming columnar. What do you call that change? The change of the cell from one cell type to another cell type. What do you call it? You call it metaplastic change. You call it metaplasia or metaplastic change from one cell type to another cell type. Metaplasia itself is not abnormal. Okay, if it is happening in, for example, the development of fontanelle to becoming bone, that is metaplastic change, that is normal. But this is not normal. Metaplastic changes occurring in the esophagus is not normal. So when the esophagus now has a columnar cell for its lining instead of the squamous cell, the esophagus now is called Barrett's esophagus. And Barrett's esophagus is a risk factor for possible development of esophageal cancer. So GERD and hiatal hernia is a risk factor for possible development of esophageal cancer. That's a danger of having GERD, and that's a danger also of having hiatal hernia. Now, how do we diagnose our patients? Diagnostic tests. Diagnostic tests. Okay. Diagnostic test, of course, the most definitive diagnostic test is visualizing it, no? Correct. Your esophagoscopy. This is an endoscopic examination. Visualize the esophagus. That's correct. Okay. Number two, we may do barium swallow. Barium is a dye. You let the patient swallow the barium and get the film of that, so you'll be able to see the hiatal hernia. Class, remember this. Barium is a dye. Of course, we need to ask for history of allergy. Allergy in general, but not allergy to seafood, because barium is non-iodinated. Again, the barium is non-iodinated. And then after the barium swallow, you tell the patient to drink a lot of water so the patient can get rid of it, right? Okay. So these are the most definitive diagnostic tests. Okay. Non-iodinated. It does not contain iodine. Okay, I will write that. Okay, barium does not contain iodine. It's non-iodinated. So there is no use of asking for history of allergy to seafood. Okay, if the patient will have to undergo angiography, they will use a dye that is iodinated. So you have to ask for history of allergy to seafood, because they may be allergic to the dye, but barium does not contain any iodine. You don't need to ask for history of allergy to seafood. You ask in general for history of allergy, but not specifically to seafood because that is not iodinated. Did you get it? Okay. Very good. Okay. These two are definitive already for hiatal hernia. Okay, but if you want to do what else? Abdominal plate abdomen, X-ray of the abdomen, that's okay, or ultrasound, that's okay. But these two is enough to diagnose our hiatal hernia. Okay, so how do we manage? The goal in the management of hiatal hernia is to prevent reflux. To prevent reflux. This is the goal in the management, to prevent reflux. So if you are managing a patient with hiatal hernia, bear in mind that all independent interventions that you will do is to prevent reflux. Okay? So what are those nursing management? So Bray, you'll start off with your independent nursing intervention. Okay? So 1, stay upright 1 to 2 hours. 1 to 2 hours after eating. You do not want to have a reflux, diba? Or, yes, that's correct. Do not lie down after eating. Okay, and of course, no bedtime snacks. Siyempre. Now, if you want to prevent reflux at night, we have to elevate your head of bed 6 inches for sleep to prevent nighttime reflux. Okay. What else? Avoid food or drinks that may decrease the lower esophageal sphincter. Okay, like what? Like soft drinks, like alcohol. You know, when you eat, as soon as the bolus of food reaches the stomach, the lower esophageal sphincter will close. And there are food that will decrease this pressure at the lower esophageal sphincter. So you have to avoid all the food and drinks that may cause this, like soft drinks, alcohol, fatty food, chocolates, yeah, that may cause GERD. And some drugs, no? Avoid drugs that also, okay, that may decrease the lower esophageal sphincter. Spicy food, yes, that may also cause GERD. Okay, what is the example of the drug? Fosamax, the one that is used for osteoporosis. Valium, diazepam, yes, it can also cause GERD. Okay, so we have to avoid all of this. Okay, can I change the page? Shall I change the page now? Is it okay with everyone that I am still lecturing like this? Yes, okay, very good. Thank you. Okay, so I will not need to ask you. So tomorrow we'll have lecture also. Yes. Same time, of course. This is CA1. Hello. Yes. Okay, can I change now? Change. I thank you. Okay, what else? Number 7. Avoid activities. 7. Avoid activities that increases or that increase intra-abdominal pressure, like straining, stooping, lifting heavy objects. Okay. Number 8, avoid constrictive clothing. Okay. Avoid constrictive clothing. Okay, that may cause GERD. Okay. And then we may give antacids. Antacids to neutralize acidity. That remember that antacid should be given after meals, usually 30 minutes to 1 hour after meals. We may give H2 receptor blockers, H2 receptor blockers like ranitidine to decrease hydrochloric acid production. Okay? But the best drug for GERD, is PPI. This was a board exam question. This is proton pump inhibitors. Okay, example is omeprazole, esomeprazole. Yan. Okay, so the action of this is also to decrease the production of hydrochloric acid. To decrease hydrochloric acid production. To decrease hydrochloric acid production. Okay, this is the best drug for GERD. Your PPI is the best drug for GERD. Ma'am, how about surgery? Surgery. Have to repair the hernia. Surgery. The surgery will come in as a last resort. Okay, last resort. Why? Because when you do correction of hiatal hernia, you have to open up the thoracic cavity and the abdominal cavity as well. So it becomes a very invasive. It will require a lot of tissue damage. So as much as possible, we need to prevent the reflux, okay, and avoid surgery. Surgery will be involving too much tissue damage, right? Okay, so this is how we manage patients with hiatal hernia. Okay, now for femoral hernia, if I may say, ano po ulit ang medication na appear sa board exam? PPI. The board exam question was, what is the best drug for GERD? The answer is, the best drug for GERD is PPI. That's the best drug for GERD. Sorry. Okay. So, when you say inguinal hernia for men, usually there is protrusion of the intestine here into the scrotum. This is your inguinal hernia. Okay, for females, femoral hernia is here. Okay, so what do you call the surgery for repair? You call it herniorrhaphy. Is that an emergency surgery? No. No, that's not an emergency, an elective surgery. Now, the danger of the inguinal hernia is strangulation. Meaning, if the intestine cannot be, it cannot go back to the abdomen, okay, it may be strangulated. So if this part of the intestine will be strangulated, there will be ischemia, there will be injury and necrosis of the intestine. So that will require an emergency surgery. So strangulation of the hernia is the reason for an emergency surgery. Otherwise, herniorrhaphy is elective, and herniorrhaphy is done under local anesthesia. Is inguinal hernia po genetic? Actually, I can say it can be familial. You know what, class? We cannot question the genetic predisposition of a person to any disease, so long as the member of the family has it. So most likely you can have it as well. We cannot question that, right? So I would just say yes. Okay, so this is how we manage your hiatal hernia. And of course, the last for our non-inflammatory condition is liver cirrhosis. Mukhang hindi ko na yun matatapos. Oh, mukhang hindi na, no? Okay, let us just have the introduction, okay? Liver cirrhosis is a condition characterized by fibrosis or scarring of the liver. Reversible or irreversible? irreversible, irreversible, and progressive, irreversible, and progressive. Okay, so what is etiology? What are the possible causes? The most common cause of liver cirrhosis is alcohol. That's correct. So you call it alcoholic cirrhosis, or this is also being referred to as your Leydig cirrhosis. Okay. Another possible cause is infection. Very good. Your hepatitis B, hepatitis C infection can cause liver cirrhosis. Okay. What else? Drugs, hepatotoxic effects of drugs and certain chemicals can cause this as well. Okay, so drugs and chemicals. So what else? What else? Hepatoma, cancer of the liver, can also cause liver cirrhosis, and it is also caused by idiopathic causes. But of course, there are certain risk factors also, like obesity, high fat diet, etc. So those are the different types, no? In patients with infectious causes of liver cirrhosis, the infectious causes of liver cirrhosis and hepatotoxic causes of liver cirrhosis, okay, the cirrhosis is called post-necrotic cirrhosis. Post-necrotic cirrhosis. Now, for idiopathic cause, it can be biliary cirrhosis. It can happen without any known cause. So, the clinical manifestations will be coming from alteration of the liver function. So remember this was a past board exam question. Since we destroy the liver, do we alter liver function? Of course. So the signs and symptoms of patients with liver cirrhosis will come from two problems. Number one, liver dysfunction, because there is alteration in the liver function, number one. And number two, because of portal hypertension. Because of portal hypertension. So if you know the functions of the liver, you just need to alter it and you see the signs and symptoms. Okay, now the liver is the largest internal organ and it has a very special circulation. The liver has two veins and one artery. The liver has portal vein, hepatic vein, and hepatic artery. So it has a very special type of circulation. So if there is liver cirrhosis, do we alter also the portal circulation? Yes. So that can lead to portal hypertension. We can discuss this pathophysiology tomorrow for the discussion of liver cirrhosis. So maybe what I will do is to finish the discussion of liver cirrhosis first, and then I will give you a question-based so we can review our peptic ulcer disease, gastritis, and all the other inflammatory condition. We need to discuss a lot because I think we will be discussing cardiovascular and respiratory disorders pa. Baka maghingi na ako ng help. Maybe I will be asking help from other professors, no, para help me out in the discussion of MS1. Baka magsawa na kayo sa akin. Okay, so it's almost 8 o'clock. Can we continue tomorrow?
Yes.
Yes. Oh, yes. So did we learn something today?
We learned a lot more.
So thank you so much, Hannah. Okay. May I ask question, ano po yung category ni liver dysfunction? And we will discuss that tomorrow, anak. Liver dysfunction and portal hypertension. Okay? Okay, so we will be discussing that tomorrow. Okay, so do you have any more questions? No more questions? My foreign students, do you have any questions? Do you understand? Pwede pong makahingi ng modules ng CA, yung antipolo. If meron po. Your modules are in your Canvas. Nasa Canvas yan, pa-open nyo lang. Okay. Tama, nasa Canvas yan. Tanong nyo kay Survey. Siya kaya gumawa nun. Nasa Canvas yan. Okay? Alright, sige. If you don't have any more questions, thank you very much. I'll see you tomorrow for the part 2 of the liver cirrhosis and the question-based discussion of inflammatory conditions of the digestive system. Sir V, thank you. Bye-bye. God bless everyone. Ingat po.
Thank you.
God bless po. Thank you so
Thank you,
much.
Doc.
Thank you,
Doc.
Thank you po, Doc.
Thank you po.
Thank you, Doc.
Anytime.
Thank you, Doc.
See you po. Bye.
Thank you.